Welcome back to the deep dive. Today we are tackling a really big one, a cornerstone unit in med-surg nursing, respiratory system problems.
Absolutely. And this isn't just about, reviewing facts. We're aiming to synthesize a whole lot of information here.
Yeah, from the basic A&P right up to managing life-threatening emergencies, we want to help you connect the dots for sharper clinical judgment.
That's the goal. We're covering chapters 24 through 29. So if you're prepping for exams or maybe heading into a clinical rotation with high acuity patients, this is really the core knowledge you need.
And the two big concepts weaving through absolutely everything we'll discuss today are gas exchange.
And perfusion, they're inseparable.
Totally. The respiratory system, it's the body's gateway for oxygen in, CO2 out. If that system struggles with ventilation just moving air,
Or diffusion, getting those gases across the membrane.
then the whole body feels it. Every single condition we talk about, whether it's asthma or a PE, it's fundamentally blocking efficient gas exchange.
Which then messes with perfusion everywhere else. Keep that connection in mind, and honestly, the purpose behind every intervention, every assessment point, it just clicks.
Okay, great foundation. Let's get into it. So let's start with the basic machinery, the anatomy and physiology. The upper airways, nose, sinuses, pharynx, we know their job, right? Filtering, warming, humidifying air, kind of the prep station.
Exactly. But where things get really critical, structurally speaking, is deeper down.
In the lower airways.
Yeah. The bronchi, the bronchioles, the alveoli,
Yeah.
there's a key difference. The bigger airways have cartilage rings, keeps them open. But when you get down to the terminal bronchioles,
No more cartilage.
nope. They rely completely on the elastic recoil of the lung tissue around them to stay open.
So that makes them vulnerable.
Extremely vulnerable, prone to collapse atelectasis. That lack of structural support is a really key point.
And the scale of this system is just, wow. The source mentions about 290 million alveoli in healthy lungs.
Providing a surface area for gas exchange that's roughly the size of a tennis court.
Incredible. A huge area for diffusion to happen.
And that diffusion isn't just random, it's tightly controlled. Which brings us to, I'd argue, the single most important physiological concept in this whole unit.
Let me guess. The oxygen hemoglobin dissociation curve.
You got it, that S-shaped curve.
It's honestly brilliant. It's like the body's built-in smart delivery system for oxygen. Make sure it gets dropped off where it's needed most and not wasted elsewhere.
Perfectly put.
Hmm.
The curve shows how tightly hemoglobin holds onto oxygen, and that changes based on the local tissue environment. So when tissues are working hard, metabolically active.
Like during exercise or with a fever.
Exactly. You see what's called a right shift. This happens when there's increased temperature, increased carbon dioxide, or a decreased pH, meaning acidosis.
Okay, so those conditions signal high demand.
Right. Hemoglobin sees those signals and says, okay, gotta let go of the oxygen faster here. It unloads oxygen more readily to protect those active tissues. It's a protective mechanism.
So thinking about a septic patient, high temp, likely acidotic, their curve is shifted right, dumping oxygen to try and meet that massive demand.
Precisely. Now, the opposite scenario is the left shift.
So decreased temp, decreased CO2, maybe alkalosis.
Correct. In those conditions, hemoglobin actually holds onto the oxygen more tightly
Why would it do that?
to prevent wasting oxygen. If the tissues aren't demanding it, hemoglobin keeps a tighter grip, ensuring oxygen isn't just released where it's not metabolically needed right then.
That has major clinical implications, doesn't it? Especially thinking about, say, blood transfusions.
Huge implications. Banked blood, stored blood, loses some of its 2-valent-3-DPG over time.
And 2-valent-3-DTG helps oxygen release.
Right. So lower 2-val-3-DPG means the hemoglobin in that transfused blood binds oxygen more tightly. It shifts the curve to the left.
So even if the pulse ox reading, the SpO2, looks okay after a transfusion.
The actual delivery of oxygen to the tissues might be less efficient because that hemoglobin is being stingy with its oxygen load. It's
Right.
why we monitor patients so closely, especially with massive transfusions. The numbers might look good, but functional delivery could be lagging.
Fascinating. Okay, let's shift to the bedside assessment. History first. Beyond the basics, smoking history is obviously crucial.
Absolutely. And it needs to be documented properly in pack years. That gives us a quantifiable measure of exposure.
We also need to think about medications, right? Some common ones can cause respiratory issues.
Definitely. ACE inhibitors are a classic example of persistent dry cough they can cause.
Mm-hmm.
And then there are higher risk drugs like bleomycin, a chemo agent, or amiodarone for heart rhythm problems. Both of those carry a significant risk of causing pulmonary fibrosis.
Which is serious, irreversible scarring of the lung tissue.
Exactly. Restrictive lung disease. So med reconciliation is critical.
In environmental history, too. The source highlights a specific tool for this, the I prepare model. Can
Mhm.
you walk us through that acronym?
Sure. iPrepare helps us systematically check for exposure to particulate matter, dusts, fumes, chemicals. It stands for investigate present work, past work, residents, where do they live,
Yeah.
near factories, old building, environmental concerns, pediatric considerations, if relevant, activities. This is a big one, hobbies. Think woodworking, painting, welding, ceramics.
Things people might not connect to their breathing problems.
Right. Then referrals needed. And finally, educate the patient on avoidance or protection. It's a really comprehensive way to uncover potential links.
Very useful. Now, we also have to consider age-related changes. The respiratory system isn't immune to aging.
Unfortunately not. As people get older, several things happen. There's a natural decrease in the alveolar surface area.
Less space for gas exchange.
Right. Elastic recoil decreases, so exhaling fully takes more effort. The cough reflex becomes less effective, making it harder to clear secretions.
Pulmonary hygiene becomes tougher.
Exactly. And structurally, the chest changes shape. The anteroposterior diameter front to back increases relative to the lateral diameter. The thorax essentially gets shorter and wider.
Which impacts lung volumes. So what's the nursing implication here?
It means older adults need more proactive support. We really need to encourage pulmonary hygiene turning, coughing, deep breathing, using incentive spirometers, especially if they're ill or post-op. And, importantly, planning for increased rest periods, because breathing just takes more work for them.
Okay. And there's a really important safety consideration mentioned regarding pulse oximetry.
Yes, this has gotten a lot more attention recently. The source points out that standard pulse oximetry readings, the SpO2, can sometimes be falsely lower in individuals with darker skin tones.
Due to the pigmentation in the nail bed interfering with the light sensor?
That's the understanding. It might mask true oxygen saturation levels, or conversely lead to giving unnecessary oxygen if we rely solely on that number.
So what's the recommendation?
We need to correlate the SpO2 with other findings. Check the color of the oral mucosa, the inside of the mouth, which is a better indicator of central tissue perfusion. Or, the gold standard, if there's concern, is an arterial blood gas, an ABG. Don't rely only on the finger probe, especially in darker-skinned patients.
Good point. Moving to the physical exam. Inspection. We need to objectively describe difficulty breathing, right, using a dyspnea scale.
Yes, like the one referenced as Table 24.2. Using a standardized scale helps us classify the severity. Are they breathless only with heavy exertion or walking on level ground or even at rest? It makes documentation consistent.
We also look for structural changes, like that barrel chest you mentioned, the 1.1 AP to lateral ratio, and retractions.
Retractions are a sign of significant distress. That's when you see the skin and muscles between the ribs or above the clavicles getting sucked inward during inhalation. It means the patient is using accessory muscles forcefully, fighting for air.
Okay, then palpation. Feeling the chest, what are we looking for?
Two key things immediately. First, chest expansion symmetry. Put your hands on their back, have them take a deep breath. Do both sides move equally? If one side lags.
Could be something limiting expansion on that side, like fluid or air. A pneumothorax.
Exactly. Second, and this is critical, you palpate for crepitus.
That crackling feeling under the skin, like Rice Krispies.
That's the one. It's subcutaneous emphysema. Air has leaked out of the airway or lung and into the surrounding soft tissues. If you feel crepitus, especially near a wound, a chest tube site, or importantly, a tracheostomy.
That's an immediate report, right? Could signal a serious air leak.
Absolutely. Report it immediately. It could be a pneumothorax developing.
Okay, and what about fremitus? Feeling for vibrations during speech.
Fremitus is fascinating. It's the vibration you feel in the chest wall when the patient speaks, like saying 99. The key is how it changes based on what's underneath.
How so?
Well, air and fluid don't transmit vibrations well. So if there's air in the pleural space, like a pneumothorax, or fluid, like a pleural effusion,
Fremitus decreases.
correct. It feels weaker or absent over that area. But if the lung tissue becomes dense and solid, like with pneumonia consolidation or a lung abscess,
It transmits vibration better.
exactly. So fremitus increases over areas of consolidation. It's a neat bedside clue.
Very cool. All right, diagnostic procedures. We already touched on pulse oximetry. Emphasizing those critical thresholds, below 91% is an emergency in someone without chronic lung disease. Below 86% is really bad, and below 70%.
Usually life-threatening. Immediate action needed.
Then there's capnometry or capnography, measuring end-tidal CO2, the PETCO2.
Right. It measures the CO2 in the air they breathe out. It's an indirect look at the arterial CO2, PECO2, but it's super useful, especially non-invasively.
How is it used clinically?
Well, a sudden drop in PECO2 can be a sign of poor pulmonary perfusion. Think about a pulmonary embolism. Blood flow is blocked, so less CO2 is getting picked up and exhaled. It can be an early warning sign.
And in CPR.
Vital for checking CPR effectiveness. If you're getting good chest compressions and circulating blood, you should see a reasonable SpO2 reading. If it drops low, your compressions might not be effective.
Makes sense. Then we have pulmonary function tests, PFTs.
PFTs give us those baseline lung volumes and flow rates. Things like FVC, forced vital capacity, FEV1, forced expiratory volume in 1 second, PEF, peak expiratory flow. We compare the patient's results to predicted values based on their age, height, sex, and ethnicity. Essential for diagnosing and tracking chronic diseases like asthma or COPD.
Okay, in invasive procedures, bronchoscopy is a big one.
It is. Going in with a scope to look directly at the airways.
Yeah.
Used for diagnosis, getting biopsies or sputum samples, removing foreign bodies, even placing stents.
Patient safety is paramount here, starting with identification.
Always. National Patient Safety Goal. Use 2 unique identifiers before any procedure. But with bronchoscopy, there's a specific dangerous risk related to the anesthetic sometimes used.
You're talking about benzocaine spray and methemoglobinemia.
Exactly. Benzocaine, used as a topical anesthetic in the throat, can trigger methemoglobinemia in some individuals. It changes the iron in hemoglobin so it can't bind oxygen effectively.
What are the warning signs? How do we recognize it?
It's dramatic. The patient becomes cyanotic, bluish. But here's the key. The cyanosis doesn't improve even when you give them 100% oxygen.
Because the hemoglobin itself is the problem, not the oxygen supply.
Precisely. And if you were to draw blood, it classically looks chocolate brown. It's an emergency. Stop the procedure, notify the provider, call the rapid response team immediately. There's an antidote, methylene blue, but it needs to be given fast.
Wow, critical point. And after any lung biopsy, whether it's transbronchial during a bronchoscopy or a needle biopsy through the chest wall or an open biopsy, what are the top post-procedure monitoring priorities?
2 major things to watch for constantly. First, pneumothorax. Listen carefully for diminished or absent breath sounds on the side where the biopsy was done. Any shortness of breath, increased respiratory rate, or O2 desaturation is suspicious.
And the second?
Bleeding. Specifically, hemoptysis, coughing up blood. A little blood-streaked sputum might be expected, but frank blood or persistent coughing of blood is a sign of hemorrhage and needs immediate attention.
Okay, we've got the assessment foundation. Now let's talk about intervening when gas exchange starts to fail, starting with oxygen therapy itself from Chapter 25. Oxygen is medicine, and too much can be harmful.
That's right. Oxygen toxicity. It's a risk with prolonged exposure to high FiO2, high concentrations of oxygen. Interestingly, the damage it causes to the lungs is very similar pathophysiologically to ARDS.
How does it manifest? What are the early signs?
Initially, it can be subtle. Maybe some dyspnea, a non-productive cough, some chest pain or burning often felt right under the sternum, maybe some GI upset. As it progresses and exposure continues.
You get more significant damage.
Yes, you start seeing decreased vital capacity, atelectasis develops, pulmonary edema can occur, and gas exchange worsens significantly. The bottom line is always use the lowest FiO2 possible to achieve adequate tissue oxygenation. Titrate it carefully.
If we do need high FiO2 non-invasively, the non-rebreather mask is often the go-to. Delivers over 90% oxygen if used correctly.
Correct, but used correctly is key. There's an essential safety check.
What's that?
You have to ensure the flow rate, usually 10 to 15 liters per minute or even higher, is sufficient to keep the reservoir bag inflated throughout the entire breathing cycle, both inhalation and exhalation.
If the bag collapses on inhalation,
The flow rate isn't high enough and the patient isn't getting the intended high FiO2. They might also start rebreathing CO2. You also need to check that the one-way valve between the mask and bag is working, and the little rubber flaps over the exhalation ports are intact and functioning. They should open on exhalation, close on inhalation.
got it. Hourly checks on that bag inflation and valve function. Now, moving beyond just passive oxygen delivery, let's talk NIPPV, non-invasive positive pressure ventilation, CPAP, and BiPAP.
These are huge tools for potentially avoiding intubation. CPAP stands for continuous positive airway pressure. It delivers one constant level of pressure throughout both inspiration and expiration.
What's the main goal of CPAP?
Its primary job is to keep the alveoli open, essentially acting like a pneumatic splint. It prevents alveolar collapse, especially at the end of expiration, which improves oxygenation. Think of it for conditions like pulmonary edema or atelectasis.
On BiPAP.
BiPAP is bilevel positive airway pressure. It provides 2 different pressures. A higher pressure when the patient inhales, IPPAC inspiratory positive airway pressure, to help them take a bigger breath and improve ventilation.
And a lower pressure when they exhale.
Exactly.
Yeah.
EPAP, expiratory positive airway pressure. That lower pressure makes it easier for the patient to breathe out against the machine. It's often better tolerated, especially by patients who feel like they're fighting CPAP or those who need help blowing off CO2, like in a COPD exacerbation.
We're also seeing high-flow nasal cannula, HFNC, used more and more, especially as an alternative to masks, say, after extubation. What are the advantages there?
HFNC delivers heated, humidified oxygen at very high flow rates, up to 60 liters per minute, through a special nasal cannula. While studies show it's often just as effective as NIPPV masks in preventing reintubation in high-risk patients.
The big win seems to be tolerance.
Absolutely. Patients generally find it much more comfortable than a tight-fitting mask. They can talk, they can eat, they can manage their secretions more easily because their mouth isn't covered. That improved comfort often leads to better adherence and potentially better outcomes because they keep the therapy on.
Makes sense. Okay, if non-invasive methods aren't enough, or if long-term airway access is needed, we move to tracheostomy. Post-op priorities for a fresh track.
Number 1, 2, and 3 is airway patency. Immediately after placement, confirm bilateral breath sounds, make sure the tube isn't down the right main stem. Then, hourly respiratory assessments are crucial for at least the first 24 hours.
What are the big complications we're watching for right away?
Tube obstruction is a major one. Look for difficulty passing a suction catheter, thick secretions that you just can't clear, or if the patient is on a ventilator, rising peak inspiratory pressures.
Well,
Pneumothorax is always a risk with neck-chest procedures. Listen for breath sounds, watch O2 sats. And subcutaneous emphysema, that crepitus we talked about around the stomach, could mean air is leaking.
suctioning is obviously key to maintaining patency, but it's not without risks.
The big immediate risk is vagal stimulation. The trachea is rich with vagal nerve endings.
And stimulating the vagus nerve can cause.
A sudden, sometimes profound, drop in heart rate bradycardia and blood pressure hypotension. If you see that happen during suction,
Stop immediately.
stop suctioning immediately. Pull the catheter out. Manually ventilate the patient with 100% oxygen using a bag valve mask until their heart rate and blood pressure recover. To minimize the risk, always hyperoxygenate before suctioning, limit suction passes to 10-15 seconds, and keep the suction pressure appropriate, usually 80 to 120 millimeter Hg.
Got it. And the ultimate safety issue, especially in the first few days with a new track, is preventing it from accidentally coming out decannulation.
This is a huge safety alert. In the first 72 hours, the tract, the tunnel from the skin to the trachea, isn't mature yet. If the tube comes out, the hole can close up very quickly, making reinsertion extremely difficult or impossible.
So securing the tube is paramount.
Absolutely. The rule is, never remove the old tracheostomy ties or holder until the new ones are securely in place. Changing ties, especially in those first 72 hours, should ideally be done by 2 people. One stabilizes the tube itself, the other secures the new ties.
How tight should the ties be?
Snug, but not too tight. You should be able to slip one finger comfortably between the ties and the patient's neck. Too loose, it can come out. Too tight, it can impede venous drainage or cause skin breakdown.
What if, despite best efforts, the tube does accidentally come out?
If it's a mature stoma, meaning it's been in place for more than 72 hours, the tract is usually stable. You might be able to quickly reinsert the same size tube or one size smaller, often using the obturator that comes with the tract tube to guide it. Keep the obturator and a spare tract tube of the same size and one size smaller at the bedside at all times.
But if it's a new track, first 72 hours.
That's an emergency. Stay with the patient, call for help immediately, including the rapid response team and respiratory therapy. You might try to keep the stoma open using a sterile curved hemostat or even the sterile obturator just to maintain the opening. But if you can't get the tube back in quickly,
The priority shifts.
priority shifts to ventilation. Cover the stoma with a sterile gauze dressing and ventilate the patient using a bag valve mask over their nose and mouth. Get ready for potential reintubation from above.
Okay. And finally, aspiration risk with the track.
It's a constant concern because the tube bypasses some of the natural airway protection mechanisms. Key strategies include keeping the head of the bed elevated, especially during and after meals, at least 30 degrees for 30 minutes post-meal.
Food and liquid consistency matters too.
Big time. Often need small, frequent meals. Liquids usually need to be thickened to nectar or honey consistency. Thin liquids are often avoided, as are straws, which can increase aspiration risk. Close monitoring during meals is essential.
All right, let's move to chapter 26, focusing on upper airway obstruction and trauma. Obstruction is obviously life-threatening. What are common causes?
It can be anything that blocks airflow from the nose mouth down to the larynx. Tongue edema, or simple occlusion by the tongue falling back in an unresponsive patient, is common. Laryngeal edema from anaphylaxis, burns, or infection. Foreign body aspiration, trauma. And, sadly, a preventable cause. Thick, dried secretions, what the text calls inspissated secretions. This can happen from poor oral hygiene combined with dehydration. The mucus gets so thick and crusty it literally plugs the airway. Preventable with good mouth care and hydration.
What are the immediate signs that someone has a critical upper airway obstruction?
Look for intense anxiety, maybe panic, that classic feeling of impending doom. Physically, diaphoresis, sweating, tachycardia, severe sternal and intercostal retractions. And the key sound,
Stridor.
stridor, that high-pitched, harsh whistling sound heard mainly on inspiration. It means air is being forced through a severely narrowed upper airway. It's an emergency sound. Cyanosis is a later, more ominous sign.
Intervention needs to be lightning fast. If we anticipate swelling, like after smoke inhalation.
Intubate early, before the edema makes it impossible. Don't wait. If intubation fails or is impossible because the obstruction is already too severe.
What's the emergency airway procedure?
A cricothyroidotomy. It's a surgical opening made through the cricothyroid membrane, which is below the thyroid cartilage, Adam's apple, and above the cricoid cartilage. Can be done with a scalpel or even a large bore needle as a temporary life-saving measure to bypass the obstruction higher up.
Okay, shifting to a chronic obstruction. Obstructive sleep apnea, OSA.
Right. Defined as periods of apnea breathing stops lasting at least 10 seconds, happening at least 5 times an hour during sleep.
And the cause is physical obstruction.
Yes. During sleep, the muscles of the upper airway relax, especially the tongue and soft palate. In susceptible individuals, they relax so much they collapse and block the pharynx.
What happens physiologically then?
Airflow stops. Oxygen levels drop. CO2 levels rise. pH decreases. This acidosis and hypoxia trigger chemoreceptors, causing a brief arousal from sleep, often just enough to restore muscle tone and open the airway, usually with a loud snort or gasp. Then they fall back asleep and the cycle repeats, sometimes hundreds of times a night.
Who's at risk?
Obesity is the biggest risk factor. Also, having a large uvula, a short or thick neck, smoking, and large tonsils or adenoids.
What are the telltale symptoms besides the partner complaining about loud snoring?
The hallmark symptom for the patient is excessive daytime sleepiness. They just feel exhausted, never rested, even after a full night in bed. Morning headaches are common. Some also report irritability, difficulty concentrating, and even nighttime GERD symptoms due to the pressure changes in the chest during the apnea events.
How is it managed?
Lifestyle changes are first line. Weight loss if indicated, avoiding alcohol and sedatives before bed. Positional therapy, avoiding sleeping on the back. But the mainstay of treatment for moderate to severe OSA is positive airway pressure therapy.
CPAP or sometimes BiPAP again.
Exactly. CPAP is most common. It acts like that pneumatic splint we talked about, keeping the airway open during sleep. BiPAP might be used if CPAP pressures are very high or if the patient also has hypoventilation.
Adherence is notoriously difficult with CPAP. What's key for patient education?
It's critical. They need to understand why they're using it. The long-term risks of untreated OSA include hypertension, heart disease, stroke, arrhythmias. They need to use it every time they sleep, including naps. Proper mask fit is essential to prevent leaks and discomfort. Daily cleaning of the mask and tubing is important to prevent infections. Reinforce avoiding alcohol sedatives. Support groups can also be really helpful.
If CPAP fails or isn't tolerated, surgery might be an option.
Yes, procedures like uvulopalatal UPPP, to remove excess tissue, or sometimes more complex jaw advancement surgeries. But surgery isn't always curative, and it has risks. Post-op, the immediate priority is airway patency due to swelling.
And the critical rescue sign post-op?
Assess hourly for signs of airway narrowing. Listen for stridor. Look for drooling, inability to swallow secretions. Check oxygen saturation closely. Any sign of compromise needs immediate intervention.
Okay, let's touch on facial and laryngeal trauma. Nasal fractures or rhinoplasty post-op care priority.
Bleeding, specifically posterior nasal bleeding. The key sign to watch for is frequent swallowing.
Because the blood is dripping down the back of their throat.
Exactly. If you see a patient constantly swallowing after nasal surgery, grab a pen light, look at the back of their throat for blood, and notify the surgeon. Management includes keeping them in a semi-Fowler's position, applying ice, and reminding them not to blow their nose, sniff forcefully, or sneeze with their mouth closed, as that can dislodge clots.
And what about severe jaw fractures requiring intermaxillary fixation, IMF, having the jaw wired shut?
This is a major non-negotiable safety alert. The patient must keep wire cutters with them at all times, always,
Why?
because if they vomit, they cannot open their mouth to clear their airway. The risk of aspiration is immediate and life-threatening. They have to be able to cut the wires instantly if they feel nauseous or need to vomit. Airway always comes first. They need clear instructions on how and when to cut the wires and to seek immediate medical attention afterwards for rewiring.
Wow, that's intense. Finally, in this section, head and neck cancer often requires complex surgery, like laryngectomy.
Yes. Devastating diagnosis with huge impacts on breathing, eating, communication, appearance. Requires a massive interprofessional team approach: oncology, nutrition, speech therapy, respiratory therapy, nursing.
Surgery can be partial or total laryngectomy. What's the key difference airway-wise?
A partial laryngectomy might preserve some voice function and often involves a temporary tracheostomy during healing. A total laryngectomy involves removing the entire larynx. This results in a permanent separation of the airway from the esophagus. Breathing occurs entirely through a stoma, an opening in the neck.
So after a total laryngectomy, the patient has a permanent laryngectomy stoma.
Correct. Post-op, airway maintenance, and gas exchange are the absolute top priorities. They'll initially have a laryngectomy tube in place. It's usually shorter and wider than a standard track tube to keep the stoma patent while it heals.
Communication is obviously drastically altered.
Completely. With a total laryngectomy, the natural voice is gone forever. Patients need to learn alternative communication methods before surgery if possible. Options include writing, using picture boards, an electrolarynx device held against the neck, esophageal speech, learning to burp air for speech, or eventually a tracheoesophageal puncture, PEP, with a voice prosthesis.
What about aspiration risk after laryngectomy?
This is a crucial distinction. After a partial laryngectomy, aspiration is still a significant risk because the airway and esophagus are still connected, just altered. These patients need intensive swallowing therapy and often learn techniques like the supraglottic method of swallowing.
Can you describe that method?
It's a sequence to protect the airway. 1, take a deep breath and hold it, closes the vocal cords. 2, place food in the mouth and swallow while holding breath. 3, cough forcefully immediately after swallowing to clear any residue from the vocal cords. 4, swallow again. 5, breathe. It takes practice.
But after a total laryngectomy?
Aspiration of food or liquid into the lungs is physically impossible because the airway, stoma, and the esophagus are completely separate passages now. They can still aspirate oral secretions if hygiene is poor, but not food or drink they swallow. That's an important teaching point for patients and families.
Okay. And the most feared immediate post-op complication after a major head and neck surgery, especially involving the carotid artery.
Carotid artery leak or rupture. It's rare, but catastrophic. Requires vigilant assessment, hourly checks of the surgical site, and drains for any pulsation, bright red bleeding, swelling, or hematoma formation.
What do you do if you suspect a leak?
Critical rescue step. If you see pulsation or a small trickle of bright blood, do not push on it or disturb the area. Call for help. Immediately activate the rapid response team or surgical emergency team. Protect the airway.
And if it actually ruptures?
If there's a massive hemorrhage, your only action is to apply immediate, direct, constant manual pressure directly to the bleeding site. Don't let up. Maintain pressure until the surgical team arrives. It's about buying seconds to save a life.
Okay, shifting gears now to the chronic lower airway diseases in Chapter 27. Let's start with asthma. We know it's chronic, but characterized by reversible airway obstruction.
That reversibility is key. It's driven by inflammation and bronchoconstriction, often triggered by specific factors. Genetics play a role, but environmental triggers are huge.
What are some common triggers we need to ask about?
Allergens, obviously dust mites, pollen, pet dander. Irritants like smoke, strong odors, air pollution. Infections, especially viral respiratory infections. Exercise can trigger it. Exercise-induced bronchospasm. Even things like GERD, stomach acid, refluxing up can irritate the airways. And importantly, some medications.
Like NSAIDs, aspirin, ibuprofen.
Yes. In some people with asthma, NSAIDs can trigger severe exacerbations because they block one inflammatory pathway, COX, which shunts precursors down another pathway, lipoxygenase, leading to increased production of leukotrienes, which are potent bronchoconstrictors. Always ask about sensitivity to aspirin or NSAIDs.
How does asthma typically present during an assessment?
Usually it's intermittent episodes. The patient reports dyspnea, shortness of breath, chest tightness, maybe coughing. The classic sign is an audible wheeze, that high-pitched whistling sound, usually heard loudest on exhalation as air tries to get out through narrowed airways. Increased respiratory rate is common during an exacerbation.
And in severe, long-standing asthma.
You might eventually see some chronic changes, like the development of a barrel chest, similar to COPD, due to persistent air trapping over years.
How is asthma diagnosed definitively?
PFTs are key, specifically looking at FEV1 and PEF. During an asthma evaluation, they'll often measure baseline PFTs, then give the patient a short-acting bronchodilator and repeat the PFTs.
What results confirm asthma?
A significant improvement after the bronchodilator, typically an increase in FEV1 or PEF by 12% or more, and at least 200 milliliter in volume, indicates reversible airway obstruction consistent with asthma. Sometimes allergy testing or methicillin challenge testing is also done.
Okay, interventions. The treatment approach is usually stepwise, right? Based on severity and control.
It's exactly. The Global Initiative for Asthma, or GINA guidelines, provide a step care approach. Treatment intensity is adjusted up or down based on the patient's symptom control level. The medications fall into two main categories.
Controllers and relievers.
Right. Control or preventer medications are taken daily, even when the patient feels fine. Their goal is to reduce the underlying airway inflammation and sensitivity. This category includes inhaled corticosteroids, ICS, the mainstay long-acting beta agonists, LIs, usually combined with ICS, and leukotriene modifiers.
And the critical teaching point about controllers.
They do not work for an acute attack. They prevent future attacks. Patients need to understand this. Grabbing their controller inhaler during an asthma attack won't help.
So, for an acute attack, they need
A reliever or rescue medication. These are almost always short-acting beta agonists, that's like albuterol. They work quickly to relax airway smooth muscle and open the airways. Should only be used as needed for symptom relief. Over-reliance on a rescue inhaler is a sign of poor asthma control.
What about status asthmaticus? That's the scary complication.
It is. Status asthmaticus is a severe, life-threatening asthma exacerbation that doesn't respond to the usual rescue therapies. It's a medical emergency.
What does it look like clinically?
Extreme respiratory distress. The patient is struggling intensely to breathe, often using accessory muscles in their neck and chest. They might be unable to speak in full sentences. You might see neck vein distension. Wheezing might be loud, and this is critical,
Or absence.
or suddenly absent.
Oh.
If a patient who is wheezing loudly suddenly becomes quiet but is still clearly in distress, that's an ominous sign.
Why is silent chest so bad?
It means the airways are so severely constricted and swollen, and the patient is potentially so fatigued that there's hardly any air moving in or out at all. No air movement means no wheezing sound. It often indicates impending respiratory failure and requires immediate, aggressive intervention.
What's the immediate treatment for status asthmaticus?
Get help. Fast RRT or code team. High-flow oxygen. Potent systemic bronchodilators, often given continuously via nebulizer. 4V corticosteroids to tackle the inflammation. 4D fluids for hydration. Possibly magnesium sulfate 4V, which can help relax smooth muscles. And be prepared for potential intubation and mechanical ventilation if they don't respond quickly or show signs of exhaustion or that silent chest.
Okay, let's move to COPD, chronic obstructive pulmonary disease. It's really an umbrella term, isn't it?
It is. It primarily includes two conditions, chronic bronchitis and emphysema. Many patients have features of both. Asthma is also now considered a risk factor for developing COPD.
Let's focus on emphysema first. What's the core problem there?
Loss of lung elasticity. The primary cause is cigarette smoking, though genetics like alpha-1 antitrypsin deficiency can also cause it. Smoke exposure triggers inflammation and increases the activity of enzymes called proteases in the lungs.
And proteases do what?
They break down elastin, which is the protein responsible for the lung's elastic recoil, the ability to spring back after inhalation. Without good recoil, the alveoli lose their shape, become enlarged, floppy, and eventually destroyed, forming these large, ineffective air sacs called bullae.
So air gets in.
But it can't get out easily. It gets trapped.
Yeah.
This chronic air trapping leads to hyperinflation of the lungs. The diaphragm gets flattened and pushed down by the overinflated lungs.
Which makes breathing harder.
Much harder. The diaphragm is the main muscle of breathing. When it's flattened, it's inefficient. Patients have to rely more on accessory muscles, which increases the work of breathing significantly and leads to that feeling of shortness of breath. They develop these sort of uncoordinated breathing patterns.
What does the classic emphysema patient often look like?
Often thin, sometimes cachectic, because the work of breathing burns so many calories. They might have muscle wasting in the extremities. You'll see them using accessory muscles, maybe pursed lip breathing. They often adopt that orthopneic or tripod position, leaning forward, resting their arms on their knees or a table to help stabilize their chest and improve breathing mechanics. And of course, the barrel chest at increased AP diameter.
Chronic bronchitis, the other main component of COPD, is more about the airways themselves, right?
Yes. Chronic bronchitis is defined clinically as having a productive cough for at least 3 months in each of 2 consecutive years. It's characterized by inflammation of the bronchi and bronchioles caused by chronic exposure to irritants, again, primarily smoke. This leads to thickened bronchial walls, narrowed airways, and excessive mucus production, which further obstructs airflow and harbors bacteria, leading to frequent infections.
These patients are sometimes called blue bloaters.
That's an older term, less used now, but it reflects the tendency for chronic bronchitis patients to have more pronounced hypoxemia, low oxygen causing cyanosis or blueness, and often fluid retention or signs of right heart failure, cor pulmonale, leading to a more bloated appearance compared to the typically thin emphysema patient, pink puffer. But again, most patients have overlap.
Okay, a huge point in COPD management, oxygen therapy. There's been a big shift in thinking about the hypoxic drive. Can you clarify the current understanding?
For years, the fear was that giving too much oxygen to a COPD patient who relies on low oxygen levels, hypoxia, to stimulate breathing would knock out their drive to breathe, leading to respiratory arrest.
So we were taught to be very cautious, keep O2 sats maybe lower.
Yes, very cautious. However, current evidence and guidelines emphasize that hypoxia kills. While the hypoxic drive is a real physiological phenomenon, it's generally not the primary driver of respiration, even in most COPD patients. The risk of harm from untreated or undertreated hypoxia far outweighs the largely theoretical risk of suppressing respiratory drive in the acute setting.
So what's the bottom line recommendation now?
Treat the hypoxia. If a COPD patient is hypoxemic, typically defined as SpO2 below 88-90% at rest, they need oxygen. The goal is usually to titrate the oxygen flow rate, often starting low at maybe 1 to 2 Lamin via nasal cannula, to achieve and maintain an oxygen saturation, typically in the range of 88% to 92%. We're not aiming for 100%, but we absolutely need to correct dangerous hypoxemia.
That's a really important clarification. Beyond oxygen, what are key non-pharmacologic interventions? Airway clearance.
Crucial. Since both components involve airway obstruction and often mucus, helping patients clear their airways is vital. Breathing techniques are foundational.
Like pursed lip breathing.
Definitely. Teach them to inhale slowly through the nose, then exhale slowly and steadily through lips pursed as if blowing out a candle, making the exhalation at least twice as long as inhalation.
What does that do?
It creates a gentle back pressure in the airways during exhalation, kind of like CPAP does. This helps keep the smaller, non-cartilaginous airways from collapsing prematurely, allowing more trapped air to escape and reducing the work of breathing.
And effective coughing techniques.
Yes, often controlled coughing or huff coughing. Instead of one big explosive cough, which can collapse airways and be exhausting, teach them to take a moderately deep breath, then do a series of short, sharp huffs, like saying huff, 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 while contracting their abdominal muscles. This helps move mucus up from lower airways without causing collapse. Having them sit up and lean forward can also help.
Drug therapy for COPD focuses more on long-term management than asthma, right?
Generally, yes. While SABAs are still used for rescue, the cornerstone of maintenance therapy involves longer-acting agents, long-acting beta agonists, CIBs, and long-acting muscarinic antagonists, LAMAs. Often, combination inhalers containing both, sometimes with an inhaled corticosteroid, ICS as well, are used for moderate to severe disease.
And proper inhaler technique is still critical.
Absolutely critical. So many errors happen here. Studies consistently show poor inhaler technique is a major reason for treatment failure. We need to teach, demonstrate, and then have the patient show us how they use their specific device, MDI, with spacer, dry powder inhaler, etc., and correct any mistakes. It's a high-yield nursing intervention.
Exercise is important too, even though they're short of breath.
Yes. Pulmonary rehabilitation programs are key. Muscle deconditioning happens quickly when patients avoid activity due to dyspnea. This creates a vicious cycle. Less activity, more deconditioning, more dyspnea with less effort. Pulmonary rehab helps break that cycle. Even simple walking daily, pushing just until symptoms occur, resting, then continuing, can improve exercise tolerance and quality of life.
Nutrition is also mentioned as complex in COPD. Why?
Several reasons. The increased work of breathing burns a lot of calories, leading to malnutrition in some. Dyspnea can make eating difficult. But there's also a metabolic aspect. Carbohydrate metabolism produces more carbon dioxide per calorie burn compared to fat or protein metabolism.
So a high-carb meal could worsen CO2 retention.
In patients prone to hypocapnia, high CO2 levels, yes. A large carbohydrate load can increase their CO2 production, potentially tipping them into hypercapnic respiratory failure. So nutritional support often involves adequate calories and protein, but sometimes with a slightly lower proportion of carbohydrates and a higher proportion of healthy fats, along with small, frequent meals to reduce dyspnea during eating.
Okay, briefly. Cystic fibrosis,
That's right.
CF. It's genetic.
Yes, an autosomal recessive disorder caused by mutations in the CFTR gene. This gene controls chloride and water movement across cell membranes. The defect leads to thick, sticky, dehydrated mucus production in multiple organs, but the lungs are usually most severely affected.
How does that mucus impact the lungs?
It obstructs the airways, leading to reduced airflow, chronic bacterial infections, often with specific organisms like Pseudomonas, inflammation, and progressive lung damage, including bronchiectasis, permanent dilation, and scarring of the airways. Pulmonary problems are the main cause of morbidity and mortality in CF.
What are the key non-pulmonary signs?
Pancreatic insufficiency is common, leading to malabsorption of fats and proteins. This causes steatorrhea, bulky, foul-smelling, fatty stools, and malnutrition, requiring lifelong pancreatic enzyme replacement therapy taken with meals. CF-related diabetes mellitus, CFRD, also develops in many patients over time. Salty sweat is another classic sign.
Management is lifelong and intensive.
Extremely intensive. Daily, multiple times a day, airway clearance techniques are essential: chest physiotherapy, percussion and vibration, oscillating vest therapy, breathing exercises, inhaled medications like bronchodilators and eucalyptics like Dornase alpha to thin mucus, aggressive treatment of infections with antibiotics, often inhaled or IV, nutritional support with high-calorie, high-protein diets, enzyme replacement, and fat-soluble vitamin supplementation, ADEK.
And BiPAP might be used?
Yes, particularly in advanced CF disease, nightly BiPAP can help rest respiratory muscles, improve gas exchange during sleep, and manage chronic respiratory failure. It's part of the complex lifelong management plan.
All right, let's move into acute infections and emergencies, chapters 28 and 29. Starting with infections, let's talk seasonal influenza.
The flu. Highly contagious viral respiratory illness, typically rapid onset headache, fever, chills, muscle aches, fatigue, cough.
Key point about contagiousness.
People are usually contagious starting about 24 hours before their symptoms even begin, and they remain contagious for up to 5 days, sometimes longer in kids or immunocompromised people. This pre-symptomatic spread is why it transmits so easily.
Prevention.
Annual vaccination is the best defense. Everyone 6 months and older should get it. There are specific formulations now, like higher dose or adjuvanted vaccines, recommended for adults 65 and older to boost their immune response.
And if someone gets the flu?
Antiviral medications like oseltamivir, Tamiflu, zanamivir, Relenza, Baloxavir, and Xofluza can shorten the duration and severity of illness and reduce the risk of complications. But the key is they must be started early, ideally within 24 to 48 hours of symptom onset to be most effective. Plus, supportive care, rest, fluids, fever reducers.
We also need to consider pandemic infections like COVID-19.
Right. These emerge when novel viruses, often coronaviruses like SARS, MERS, and SARS-CoV-2, jump from animals to humans. Because humans lack pre-existing immunity, they can spread rapidly worldwide, causing pandemics.
Core symptoms we look for.
Often similar to flu, initially fever, chills, cough, fatigue, body aches. But COVID-19 had some more specific potential cues, like the new loss of taste or smell, which was quite characteristic for many. Shortness of breath is a key indicator of more severe disease.
Priorities for managing any suspected novel respiratory infection.
Early identification and isolation are critical to prevent spread. Initiate appropriate precautions immediately, usually droplet in contact, sometimes airborne, depending on the situation and procedures being done. Mask the patient. Get a detailed history, including recent travel or exposure. Supportive care is the mainstay: oxygen, hydration, monitoring for deterioration, and prompt testing to confirm the specific pathogen.
Okay, let's focus on pneumonia. The text calls it a gas exchange exemplar. Walk us through how infection leads to impaired gas exchange.
It starts when pathogens, bacteria, viruses, fungi, get past the airway defenses and multiply down in the alveoli. This triggers a significant inflammatory response.
Inflammation causes what?
Capillaries in the area become leaky. Fluid and inflammatory cells, like white blood cells, pour into the interstitial space around the alveoli, and then into the alveoli themselves. This creates edema, and exudate basically pus and fluid filling up the air sacs.
So the alveoli get filled with gunk instead of air.
Exactly. That consolidation, that filling of the alveoli, drastically reduces the surface area available for gas exchange. Oxygen can't easily diffuse across that thickened, fluid-filled barrier into the blood, leading to hypoxemia. Carbon dioxide might also be retained.
And if the infection spreads beyond the lungs?
If the organisms get into the bloodstream, it leads to bacteremia or viremia, which can quickly escalate to septicemia and potentially life-threatening sepsis and septic shock.
What are the common clinical signs of pneumonia?
Patients often look acutely ill. Flushed cheeks, maybe an anxious expression. Chest pain is common, often pleuritic sharp, worse with deep breaths or coughing. Fever, chills, tachycardia, tachypnea, rapid breathing. They might be coughing up sputum, which could be yellow, green, or even rust-colored or bloody hemoptysis. They might adopt that tripod position to ease breathing.
What do we typically find on physical assessment? Auscultation.
Crackles, or rales, are common, especially fine crackles, caused by air moving through fluid in the airways and alveoli. You might hear bronchial breath sounds over areas of consolidation where you normally hear vesicular sounds. That's because the dense lung tissue transmits the sound from the larger airways better.
And palpation and percussion.
Because the lung tissue is dense, you'd expect increased tactile fremitus over the consolidated area. Percussion over that area would sound dull, rather than the normal resonant sound of air-filled lung.
Key interventions for pneumonia.
Number 1 is improving gas exchange. Encourage use of incentive spirometry to keep alveoli open. Promote effective coughing and deep breathing. Ensure adequate hydration, often aiming for at least 2 liters of fluid per day unless contraindicated, like in heart failure, as this helps thin secretions, making them easier to cough up. Oxygen therapy as needed to maintain saturation.
And treating the infection itself.
Prompt initiation of appropriate anti-infective therapy is crucial. The choice depends on whether it's likely community-acquired CAP or hospital-acquired healthcare-associated HAPH-CAP, the patient's risk factors, and local resistance patterns. Antibiotics for bacterial pneumonia are typically given for 5 to 7 days for uncomplicated CAP, but can be much longer, up to 21 days, for HAP or complicated cases. Viral pneumonia is treated supportively, sometimes with antivirals if available early.
What's a potential complication of pneumonia involving the pleural space?
Empyema. That's when the infection spreads into the pleural space, the area between the lung and the chest wall, and forms a collection of pus. It requires drainage, usually via a chest tube or sometimes surgical intervention, along with prolonged antibiotic therapy.
Okay, our other major infection exemplar, pulmonary tuberculosis, TB. How is it transmitted?
Strictly airborne. When someone with active pulmonary TB coughs, sneezes, laughs, or even sings, they release tiny droplet nuclei containing the TB bacteria, Mycobacterium tuberculosis, into the air. These droplets can remain suspended for hours and be inhaled by others.
What happens after someone inhales the bacteria?
In most healthy people, the immune system walls off the bacteria, forming a granuloma. This is called latent TB infection, LTBI. The person isn't sick and can't spread it, but the bacteria are dormant. The immune response, specifically cell-mediated immunity, develops over 2 to 10 weeks, which is when a tuberculin skin test would become positive.
What's the characteristic pathology of TB?
The hallmark is caseation necrosis within the granuloma. The infected tissue dies and turns into this cheesy, granular material. If the immune system weakens later, the granuloma can break down, the bacteria multiply, and active TB disease develops. Sometimes the necrotic tissue liquefies and gets coughed up, creating a cavity in the lung.
Who is at highest risk for developing active TB?
Anyone with a weakened immune system. People living with HIV/AIDS are at extremely high risk. Others include those experiencing homelessness, incarcerated individuals, people with substance use disorders, those in lower socioeconomic groups with poor nutrition or healthcare access, and residents of long-term care facilities. Also, people on immunosuppressive medications.
How is TB diagnosed? We mentioned the skin test.
The tuberculin skin test, TST, also called the MAN2 test, involves injecting a small amount of tuberculin protein under the skin. We read the reaction 48-72 hours later, measuring the diameter of induration, the raised hardened area, not just redness.
What size induration is considered positive?
Generally, 10 millimeters or more is positive for most people. However, for high-risk individuals like those with HIV or recent close contacts of someone with active TB or organ transplant recipients, an induration of 5 millimeters or more is considered positive.
What about people who received the BCG vaccine?
That's important. The BCG vaccine, given in many countries outside the U.S. to prevent severe TB in children, can cause a false positive TST reaction, sometimes for many years. Interferon gamma release assays, IGRAs, which are blood tests for TB, are preferred for screening people with a history of BCG vaccination, as they are not affected by it. A positive TST or IGRA only indicates exposure and likely infection, latent or active, not necessarily active disease.
So how do you confirm active pulmonary TB?
Active disease requires finding the TB bacteria. This is usually done through sputum smear microscopy for acid-fast bacilli, AFB, and sputum culture for M. tuberculosis, which is the gold standard but takes weeks. Chest X-ray is also crucial, often showing infiltrates, cavities, or lymph node involvement, typically in the upper lobes.
Okay, treatment for active TB. What's the most critical factor for success?
Adherence. Strict adherence to the prescribed multi-drug regimen for the entire duration is absolutely essential. TB treatment takes a long time.
How long?
Standard treatment for drug-susceptible TB usually involves 4 drugs: isoniazid INH, rifampin RIF, pyrazinamide PZA, and ethambutol EMB, taken daily for the first 8 weeks, followed by INH and RIF for another 18 weeks, for a total of at least 26 weeks, 6 months. For multi-drug-resistant TB, MDR-TB, treatment involves second-line drugs and can last up to 2 years.
Why is adherence so vital?
Because incomplete or inconsistent treatment is the primary driver of drug resistance. If patients don't take all their meds correctly for the full duration, some bacteria survive and can mutate, becoming resistant to the drugs. This leads to MDR-TB or even extensively drug-resistant TB, XDR-TB, which are incredibly difficult and costly to treat. Directly observed therapy, DOT, where a healthcare worker watches the patient swallow every dose, is often used to ensure adherence.
The drugs themselves have significant side effects, right?
Yeah. Yes, they do. A major concern across the board is hepatotoxicity, liver damage. All the first-line drugs, especially INH, RIF, and PZA, can potentially harm the liver.
So what's the crucial patient teaching regarding this?
Patients must be explicitly warned to avoid all alcoholic beverages for the entire duration of TB therapy, as alcohol significantly increases the risk of liver damage when combined with these medications. They also need to report any signs of liver problems immediately: jaundice, yellowing skinnies, dark urine, abdominal pain, nausea, unexplained fatigue. Regular liver function tests are usually monitored during treatment.
Are there other specific side effects to warn about?
Yes. Rifampin causes a harmless but potentially alarming orange-red discoloration of urine, sweat, tears, and saliva. Patients need to know this is expected. It will also permanently stain soft contact lenses orange, so they should wear glasses instead. Ethambutol can cause optic neuritis, inflammation of the optic nerve, which can affect vision, blurriness, color vision changes. Patients need to report any vision changes immediately, as this requires stopping the drug. INH can cause peripheral neuropathy, numbness, tingling, often prevented by taking vitamin B6, pyridoxine, concurrently.
What about infection control for TB in the hospital?
Patients with suspected or confirmed active pulmonary TB must be placed in airborne precautions. This means a private, negative pressure isolation room. Anyone entering the room must wear a fitted N95 respirator mask or equivalent.
And when they go home, how do they prevent spreading it?
Teach them to cover their mouth and nose with a tissue when coughing or sneezing, and dispose of used tissues immediately in a sealed plastic bag. They should wear a standard surgical mask if they need to be around other people, especially in crowds or enclosed spaces, until they are considered non-infectious. Good ventilation at home is helpful. Family members and close contacts need to be screened for TB infection. They are generally considered non-infectious after about 2-3 weeks of effective treatment, confirmed by 3 consecutive negative sputum smear results.
Okay, let's tackle the big respiratory emergencies from Chapter 29. Pulmonary embolism, PE. It's described as both a gas exchange and a clotting exemplar.
Exactly. It starts with a clot, usually a deep vein thrombosis, VTE, that forms in the legs or pelvis. That clot breaks loose, travels through the venous system, through the right side of the heart, and lodges in the pulmonary artery, or one of its branches.
What does that blockage do to lung function?
It obstructs blood flow to a portion of the lung. This creates a major ventilation-perfusion VQ mismatch. The alveoli in that area are still getting air. Ventilation is okay, but they're not getting blood flow. Perfusion is blocked.
So gas exchange can't happen there.
Right. It's like having dead space ventilation. Oxygen can't get into the blood. CO2 can't get out from that segment. If the PE is large enough, this causes significant hypoxemia. Additionally, the blockage increases pressure in the pulmonary arteries, pulmonary hypertension, straining the right side of the heart. Platelets also aggregate on the clot and release substances that cause further vasoconstriction, worsening the situation.
Who's at high risk for PE?
Many factors: prolonged immobility, Post-surgery, long travel paralysis,
Okay.
recent surgery, especially orthopedic, pelvic, or major abdominal surgery,
Mm.
history of VTE, central venous catheters, pregnancy in the postpartum period, obesity, smoking, estrogen therapy, birth control pills, hormone replacement, cancer, and inherited clotting disorders like factor V Leiden.
What are the classic symptoms? Often sudden onset.
Yes, often abrupt. The most common symptom is sudden onset dyspnea, unexplained shortness of breath. Pleuritic chest pain, sharp, stabbing pain that worsens with deep inspiration is also very common.
What other signs might we see?
Maybe apprehension, a cough, sometimes with hemoptysis, tachypnea, tachycardia. In massive PE, signs of shock can occur. Hypotension without an obvious cause. Syncope, fainting. Patients often report a profound sense of anxiety or impending doom.
If you suspect a PE, it's a critical situation. What are the immediate nursing actions?
Act fast. Ensure the patient is stable. Raise the head of the bed to high Fowler's position to ease breathing. Apply oxygen immediately, usually via non-rebreather mask initially, to maximize oxygenation. Place them on continuous pulse oximetry and cardiac telemetry. Establish TARV access, if not already present. Notify the provider and rapid response team immediately. Stay with the patient and provide reassurance.
How is PE treated medically?
Treatment depends on the severity. For massive PE, causing shock or cardiac arrest, fibrinolytic therapy, clot busters like Ultiplas, TPA, is indicated for rapid clot dissolution, despite the bleeding risk. For most other PEs, submassive or low risk, the mainstay is anticoagulation.
Like heparin.
Yes, usually starting with an IV heparin infusion to prevent further clot formation immediately, often bridged later to oral anticoagulants like warfarin or direct oral anticoagulant DOAC for long-term treatment, typically 3 to 6 months or longer. Throughout anticoagulation, implement bleeding precautions.
Are there surgical options?
Sometimes. For massive PE where fibrinolytics are contraindicated or failed, a surgical embolectomy, physically removing the clot, might be performed. For patients with recurrent PEs or contraindications to anticoagulation, an inferior vena cava IVC filter may be placed to trap clots traveling up from the legs before they reach the lungs.
Okay, moving on to acute respiratory failure, ARF. This isn't a disease itself, right? More a state of inadequate gas exchange.
Exactly. ARF occurs when the respiratory system fails in one or both of its main functions. Oxygenation, getting oxygen into the blood, or ventilation, removing carbon dioxide from the blood. So you can have hypoxemic respiratory failure, oxygenation failure, hypercapnic respiratory failure, ventilatory failure, or a combination of both. It's usually caused by an underlying lung disease like COPD, pneumonia, ARDS, PE, or conditions affecting respiratory drive or muscles.
What's the underlying mechanism often involving VQ mismatch?
Yes, VQ mismatch is a common pathway. Either alveoli are perfused but not ventilated, shunt like in pneumonia or atelectasis, leading to hypoxemia, or alveoli are ventilated but not perfused, dead space like in PE, also contributing to gas exchange failure. In ventilatory failure, overall ventilation is inadequate to remove the CO2 produced by the body, leading to hypercapnia.
What are the classic signs of ARF?
Depends on whether it's primarily hypoxemic or hypercapnic, but often overlap. Key signs of hypoxemia include restlessness, agitation, confusion, tachypnea, tachycardia, cyanosis, late sign. Key signs of hypercapnia include headache, drowsiness, confusion, progressing to lethargy or coma, CO2 narcosis, flushed skin, bounding pulse. Dyspnea is usually present in both. Decreased level of consciousness is a critical sign of worsening ARF.
Then we have acute respiratory distress syndrome, ARDS. This is a specific severe form of ARF, right?
Yes, ARDS is characterized by acute onset, severe hypoxemia, and bilateral pulmonary infiltrates on chest X-ray, not fully explained by heart failure or fluid overload. Because ARDS involves diffuse inflammation and damage to the alveolar capillary membrane throughout the lungs. This causes widespread leakage of fluid and protein into the alveoli, leading to non-cardiac pulmonary edema. The alveoli collapse or fill with fluid, creating a massive intrapulmonary shunt blood flows past non-functioning alveoli without picking up oxygen. Surfactant is also inactivated, leading to decreased lung compliance, stiff lungs.
What does ARDS look like on imaging?
The chest X-ray typically shows diffuse bilateral pulmonary infiltrates, often described as having a ground glass appearance or progressing to complete whiteout of the lungs.
Management of ARDS is primarily supportive.
Yes, there's no specific cure. Management focuses on treating the underlying cause, 4G antibiotics for sepsis, maintaining adequate oxygenation and ventilation, and preventing complications. Mechanical ventilation is almost always required.
What's special about ventilating ARDS patients?
We use lung protective ventilation strategies. This typically involves using low tidal volumes, amount of air per breath, based on the patient's ideal body weight, not actual weight, to avoid overstretching the remaining healthy alveoli, volume trauma. We also often use positive and expiratory pressure, PEEP.
What does PEEP do?
PEEP applies pressure at the end of exhalation to keep alveoli from collapsing completely. This helps recruit or reopen collapsed alveoli, improving oxygenation and allowing for lower FiO2 settings, reducing the risk of oxygen toxicity. However, too much PEEP can decrease cardiac output or cause barotrauma, lung injury from pressure.
And we mentioned prone positioning earlier. Why is that used in ARDS?
Prone positioning, placing the patient face down, has been shown to significantly improve oxygenation in many patients with moderate to severe ARDS.
How does turning them prone help?
In the supine back-lying position, the weight of the heart and the abdominal contents compresses the lower dorsal parts of the lungs, worsening atelectasis there, while blood flow is often greatest to those dependent areas. Turning prone relieves this compression on the dorsal lung regions, allowing them to re-expand. It also helps redistribute perfusion more evenly and may facilitate drainage of secretions. It essentially improves VQ matching. It requires a skilled team and careful attention to lines in the airway.
Nutrition is also vital in ARDS.
Absolutely. These patients are hypermetabolic and prone to malnutrition. Early nutritional support, usually via enteral feeding, tube feeding, if the gut is working, is important for immune function and healing. So specific formulas might be considered.
Okay, let's talk about mechanical ventilation and intubation in general. What's the main purpose?
It's temporary life support. The goals are to improve gas exchange, oxygenation and/or ventilation, decrease the work of breathing, and allow the underlying lung condition to heal. It doesn't cure the disease, it just supports the patient until they can breathe adequately on their own again.
When someone is intubated with an endotracheal tube, ET tube, where should the tip sit?
Ideally, the tip of the ET tube should rest about 2 centimeters above the carina, which is the point where the trachea bifurcates into the right and left mainstem bronchi.
How is placement confirmed?
Initial confirmation is often by auscultating for equal bilateral breath sounds and observing chest rise. End-tidal CO2 detection is crucial immediately after intubation. But definitive confirmation requires a chest X-ray. If the tube is too deep, it usually goes into the right mainstem bronchus because it branches off at a less sharp angle, leading to ventilation of only the right lung and collapse of the left.
What's the top nursing priority once the tube is placed and secured?
Maintaining a patent airway. This involves regular suctioning as needed based on assessment of visible secretions, coughing, raunchy, ventilator alarms, ensuring the tube remains securely taped or tied, and possibly using a bite block to prevent the patient from biting down on the tube and occluding it. Tube positions should be checked regularly. Securing the tube is often a two-person job initially.
What if the patient on the ventilator suddenly develops respiratory distress? What's the immediate action and troubleshooting approach?
Critical rescue step. If a ventilated patient acutely decompensates, sudden drop in O2 sat, increased work of breathing, agitation, alarm sounding, the very first thing to do is disconnect them from the ventilator and manually ventilate them with a bag valve mask device connected to 100% oxygen.
Why disconnect first?
This immediately rules out ventilator malfunction or circuit problems as the cause. If the patient improves rapidly with manual bagging, the problem is likely the equipment. If they don't improve, the problem is likely the patient. While bagging, you quickly troubleshoot using the DOPE mnemonic.
Walk us through DP.
D stands for displaced tube. Has the ET tube moved out of the trachea or down the right mainstem? Check tube depth. Listen for breath sounds. O is for obstructed tube. Is it blocked by secretions, mucus plug, kinking, or the patient biting it? Try passing a suction catheter. P is for pneumothorax. Has the patient developed a collapsed lung, possibly from barotrauma, too much pressure? Assess breath sounds, chest rise symmetry, vital signs. E is for equipment failure. Is the ventilator malfunctioning? Is the circuit disconnected or leaking? That's why you bag them first.
That's a great framework for rapid assessment. What are some common complications of being on a ventilator long-term?
Ventilator-associated pneumonia, VAP, is a major one. Bacteria can enter the lungs around the ET tube cuff or through contaminated equipment secretions. Prevention bundles, head elevation, oral care, sedation vacations, early mobility are key. Barotrauma, lung injury from excessive pressure, or volume trauma, injury from excessive volume, leading to pneumothorax or subcutaneous emphysema. Cardiovascular effects like hypotension due to increased intrathoracic pressure reducing venous return. Stress ulcers in the stomach are common, requiring prophylactic medications like PPIs or H2 blockers. muscle deconditioning from immobility, ventilator dependence.
Weaning from the ventilator is the goal. How does that process work?
It's a gradual process of decreasing ventilator support, allowing the patient to take on more of the work of breathing. It involves assessing readiness, underlying cause resolving, hemodynamically stable, adequate oxygenation on minimal support, patient awake and cooperative, performing spontaneous breathing trials, SBTs, where the patient breathes with little or no support for a period, and monitoring closely for tolerance. If successful, they can be extubated.
Are certain patients at higher risk for difficulty weaning?
Yes, older adults are often at higher risk due to those age-related decreases in respiratory muscle strength, elastic recoil, and reserve. Patients with severe underlying lung disease, prolonged ventilation, malnutrition, or significant muscle weakness may also have difficulty weaning and might require a slower process or even tracheostomy for long-term ventilation.
Finally, let's quickly cover chest trauma causing pneumothorax or hemothorax. What's a pneumothorax?
Air in the pleural space, the potential space between the visceral pleura, lining the lung, and the parietal pleura, lining the chest wall. Normally, this space has negative pressure, which keeps the lung expanded. If air enters, that negative pressure is lost and the lung collapses partially or completely.
Can be open or closed.
Right. An open pneumothorax involves an opening in the chest wall, like a stab wound, allowing air to enter from the outside. A closed pneumothorax occurs when air leaks from the lung itself into the pleural space, like from a ruptured bleb in COPD or trauma.
What's the most dangerous type?
Tension pneumothorax. This is a true emergency. Air enters the pleural space, usually from a lung tear, but cannot escape, acting like a one-way valve. Pressure builds up rapidly in the affected side.
What does that pressure do?
It completely collapses the lung on that side and then pushes the entire mediastinum, the heart, trachea, great vessels, over to the opposite side. This kinks the great veins, severely reducing venous return to the heart, causing profound shock and potentially cardiac arrest.
Signs of tension pneumothorax.
Extreme respiratory distress, severe cyanosis, distended neck veins, JVD, tracheal deviation away from the affected side, late sign, hemodynamic instability, tachycardia, hypotension, absent breath sounds on the affected side.
Immediate management.
Immediate decompression. This is done initially via needle thoracostomy or needle decompression. A large bore needle is inserted into the second intercostal space in the midclavicular line on the affected side. You should hear a hiss of escaping air as the pressure is relieved. This is a temporary life-saving measure, followed by definitive treatment with a chest tube.
And a hemothorax.
That's blood in the pleural space, usually from trauma injuring blood vessels in the chest wall, lung, or mediastinum. A simple hemothorax is less than 1,000 milliliters of blood. A massive hemothorax is more than 1,500 milliliters or persistent rapid bleeding. Signs are similar to pneumothorax: dyspnea, decreased breath sounds, dullness to percussion, but also include signs of hemorrhagic shock if bleeding is significant.
Management for significant pneumothorax or hemothorax.
Chest tube insertion is essential. A tube is placed into the pleural space and connected to a chest drainage system. For pneumothorax, it removes the air, allowing the lung to re-expand. For hemothorax, it drains the blood. The goal is to re-establish the normal negative pressure in the pleural space. Careful monitoring of the chest tube system, drainage amount and character, and the patient's respiratory status is crucial.
Wow. We've covered an incredible amount of critical information across these chapters, from the subtle shifts in the O2-HGB curve.
Right up to the immediate actions needed for attention pneumothorax or carotid rupture, it all comes back to those core concepts.
Gas exchange and perfusion. Every assessment, every intervention is aimed at supporting one or both of those.
Exactly. And true clinical competence here isn't just memorizing facts, like the definition of ARDS. It's about recognizing the pattern, seeing the refractory hypoxemia, and understanding why proning might help. It's knowing that assessing for frequent swallowing after nasal surgery isn't trivial. It's a critical rescue aimed at preventing a potentially catastrophic bleed.
It's about seeing the early, sometimes subtle signs and intervening before the patient spirals into complete respiratory failure. Knowing that those wire cutters for the patient with IMF are non-negotiable, or that a silent chest in status asthmaticus is far more dangerous than loud wheezing.
So the final thought for you, our listeners: when you're faced with that patient whose breathing is failing, whose gas exchange is compromised, think back through this deep dive. Out of all the potential cues, the SpO2, the respiratory rate, the breath sounds, the PETCO2, the patient's anxiety level, the mechanism of injury, what critical piece of data will you prioritize first? What action will you take in that split second to potentially change the outcome? That judgment is at the heart of expert nursing care.
A perfect way to wrap up this comprehensive dive. Thank you so much for guiding us through this incredibly important and complex unit.